Hey guys, this is my name, TA for this class. I'm sure you've seen my face a bunch of times now. So I'm going to be doing the exam review for 337, and I'm just going to pull up the questions that we got in the discussion board. So the first question we received was, I'm just wondering, so since DSM-5 combined everything into one spectrum without subtypes, there are no CDD or PDD-NOS, right? In the meantime, all three of these disorders cannot be determined with the severity level, right? So as Dr. Weinberg said in class, these disorders were combined into one of autism spectrum disorder, or ASD. So do not exist as their own now in the DSM. However, it's important to note that some of these, there are specifiers that can be made in ASD. So one of the specifiers is if there's the presence of a medical or genetic condition. So we talked about how Rett's disorder, there's some epigenetic disorder. So you would give the person the diagnosis of ASD, and you would have to write in the specifier Rett's disorder, and then you could indicate the severity of Rett's disorder on that specifier. Okay. So this person, Nellie, says for lecture 16 on schizoaffective disorder, it says that 6 of major mood episode symptoms present for the majority of the illness. What does this mean? So this is for schizoaffective disorder. So we know that core criteria for schizoaffective disorder, period, which there is a major mood disorder, either depression or mania, that occurs at the same time that the symptoms of schizophrenia are present. And there has to be delusions or hallucinations for 2 or more weeks in the absence of a major mood episode. And symptoms that meet criteria for a major mood episode are present for the majority of the total duration of the illness. And of course, the abuse of drugs or medication cannot be responsible for the symptoms. So I think the confusion is if you actually look at that lecture slide, it says SX, which is referring to symptoms and not 6. So it's just symptoms of a major mood episode need to be present for the majority of the illness, not that there's 6 major mood episodes or anything like that. Okay. So the second part of that question refers to lecture 17, to when Dr. Weinberg was talking about risk factors. First, I'm going to pull up that slide. Okay. You are referring to. And so this is looking at risk for developing schizophrenia in relatives of people who have schizophrenia. So the blue is risk for the general population, and as you can see, it's pretty low, around 1%. And then for second-degree relatives, the yellow, and then third-degree relatives are in green, and then first-degree in blue. What you can see is people who have an identical twin who has schizophrenia, their risk for developing the disorder increases by about 50%. And this 100% just refers to the amount of genes shared with the person who has schizophrenia, and you have a pretty high risk of actually developing schizophrenia yourself. And this risk decreases in sort of a graded fashion, depending on the genes shared between you and the relative that actually has the disorder. So as you move away from being the amount of shared genes in an identical twin situation, your risk is going to decrease. Concordance rates were also presented, so higher risk or higher concordance in those who are monozygotic, dizygotic. So it's just indicating that this disorder is highly heritable, but of course not as much as bipolar. And then this slide was showing a similar thing of a study done in Denmark, the incident rate of schizophrenia compared to the population. And so at the top, we have parents, and this person has schizophrenia, and they're a monozygotic twin with this person. And then this offspring of them doesn't have the disorder. And you can see that the risk estimate for this offspring is 17.4%, which is larger than the risk we see in the general population, which once again just strengthens kind of the argument that this disorder is highly heritable and families. Of course, estimates of risk are going to vary from study to study, so just know what the textbook says, the different estimates that are presented in lecture in each of these different studies. Okay. So the next question. Nellie also had a question about positive versus negative symptoms of schizophrenia, which I think is a question that a lot of people had. So the first is, hallucinations can be both considered positive and negative symptoms in the sense that you have hallucinations are not there, which may be positive, or you don't see things that are actually present, negative. So hallucinations and delusions are positive symptoms. They're symptoms. And a kind of thing to keep in mind is that positive symptoms are those that appear to reflect an excess or a distortion of normal functions. And then negative symptoms are when there's sort of something missing from normal behavior, either in sort of thought patterns or emotions. So hallucinations and delusions, those are sort of the addition of something else that is not typical of normal behavior, and there's a distortion in reality. So those would always be positive symptoms. Then there are forms of thought, so things like associative looseness or concrete thinking, word salad, tangentiality, mutism. Those type of symptoms are also all positive symptoms. As well as symptoms that are related to perception, as I said, so like hallucinations and illusions. Positive symptoms would also be related to distortions in sense of self that we see in schizophrenia. So things like echolalia, echopraxia, depersonalization is also a positive symptom. We also see positive symptoms related to content of thought. So as I said, delusions, paranoia. And then there was also the question of whether all forms of catatonia are considered a negative symptom. So Dr. Weinberg actually posted a response to this on the main page. It's debated whether catatonia is a negative or a positive symptom, but the field has for a long time seen this as a negative, so remember it as a negative symptom, and that's because there's a reduced ability in the symptom to respond to the environment or your surroundings, and it can involve the person not moving from several hours to days. And for symptoms that are related to kind of relating to other people, or sort of your affective symptoms like anhedonia or avolition, those would be negative symptoms as well, and not positive. Okay, next question. So this person says, in the Temple Grandin video where she discusses what it's like to be autistic, she highlights the fact that speech was a problem for her and basically says that a child at the age of 3 is a sign that they may have autism and they should get early intervention. I'm confused as to how this comes into diagnosis, as there's no explicit mention of verbal communication problems in the DSM-5 criteria. When I think about it, I've also heard general conversations talking about ASD and speech problems. I was always under the impression that this was one of the main characteristics. Can you clarify this? So actually, deficits in verbal communication are a part of the criteria for ASD. It's not just nonverbal communication, and it can also involve verbal communication. And actually, many individuals with ASD do show language deficits, and this can range from complete speech through delays in language, poor comprehension of speech, echoed speech, stilted and overly literal. And you can see these deficits at any age, not just within childhood. And actually, if you see someone who is showing these kind of deficits in verbal communication, there's actually a specifier that needs to be given in the diagnosis of ASD. So you may give a specifier of with or without accompanying language impairment. And this may involve seeing within this patient that they have like no intelligible speech, or they're completely nonverbal. Maybe they only say single words, stuff like that. So I would say in response to this question that yes, if you saw a child who at 3 years of age, this symptom as well as the other ones specified within the ASD criteria, yes, it is actually a diagnosable symptom. Okay. The next question from Mandy is, what is the difference between cognitive slippage versus aversive drift? So this was in reference to schizotypal personality disorder, and there was a scientist named Neil, and he pointed out that these two terms, so cognitive slippage and maybe sort of core characteristics of schizotypal personality, and he suggested that cognitive slippage exists on a continuum from high to low levels and can be found in individuals with and even without schizophrenia. And cognitive slippage refers to sort of an individual's thoughts are organized in an unusual or illogical way. So it can be manifested in patterns of speech where categories and lists become overly broad, as concepts that seem unrelated at first glance become related through kind of tangential connections. So, so someone may ask, what animals did you see at the zoo today? And the person with schizotypal personality, we saw tigers, bears, dolphins, the Baltimore Ravens, the Packers, Carolina Panthers, jaguars, lions, and otters. So clearly here we see the slip occur between animal names and football teams, with animals as their mascot. So the person lists animals they saw. They mentioned bears and dolphins, which double as the names of NFL teams. And this results in a slip to a tangentially related list of football teams, then back again to animals after the mention of the Carolina Panthers, relates to the other big cats that they saw, so like the jaguars and the lions. And so the cognitive slippage is associated with an inability to identify and sort of disregard these sort of extraneous connections. And aversive drift, Meal suggested that it's sort of an intense and pervasive in the functioning, and it sort of manifests in the person as ambivalence and sort of interpersonal fear. And he theorized that anhedonia, which is a core negative symptom, would contribute or be a consequence of what he described as aversive drift. Okay. The next question is, if increased dopamine leads to more psychotic state, increased dopamine transmission in frontal lobe instead of reduced. So in lecture, we learned that is this theory that schizophrenia is associated with excessive dopamine, but it's kind of controversial at the moment. But what's currently in the field is that perhaps there is excessive dopamine in the striatum and reward-related structures, and decreased dopamine in the prefrontal cortex areas. And this makes sense that you would see less dopamine in your sort of prefrontal areas, because these areas are highly involved in executive functioning, regulating our behaviors, and of our world and our effective responses to it. So we do see that the frontal does have reduced dopamine in schizophrenia. So the next question is about the video that Dr. Weinberg posted about 4 patients' schizophrenia video. This person was unable to access the video. It's possible that other people are also experiencing this problem, so I will try re-uploading the video. If that doesn't work, I would suggest using a different web browser, or possibly using somebody else to watch this video. Okay. So the next question is, how common is epilepsy in autism? The book says 1/3 of adolescents with autism have epileptic seizures, while Dr. Weinberg said 10% have either an intellectual disability or epilepsy. So I would know both estimates. So estimates of epilepsy displayed in autism that the textbook says, but also what Dr. Weinberg says in lecture. And in the exam, if a question like that ever comes up, we'll specifically ask, according to the textbook, how common is epilepsy in autism. So the next question. In lectures, Dr. Weinberg lists a few regions that are implicated in autism and says that all the regions are involved functionally and structurally. I was wondering if this also means the regions she wrote on her slide as having structural abnormalities, like the cerebellum, also have functional abnormalities. She didn't specify this. So yes, you're right. The regions that Dr. Weinberg did specify, you see functional deficits as well as structural deficits. So things like smaller volumes in these areas as well. Okay. So the next question. The textbook mentions some important distinctions between schizophrenia and ASD. Specifically, it says that schizophrenia shows pattern of heritability and equal distribution between males and females. To my knowledge, there is a high frequency of autism among siblings of a person with autism as well, 3 to 5%. So what does that mean? So I think it's important to recordability and the distribution across male and females is going to vary, specifically in schizophrenia. So as I said earlier in the video, depending on the degree of relatedness you have with the person in your family, so as you kind of share less of your genes, the frequency of you seeing schizophrenia would be lower. But also we know that we see the prevalence of schizophrenia changes also across age, and the prevalence of schizophrenia that we see in males and females changes across age, which is having this disorder earlier in life, and females showing this disorder later in life than males do. I know that ASD and schizophrenia are highly heritable disorders, and I would know the heritability even in lecture. The second part to this question is, could you clarify why schizophrenia might be similar in diagnosis in the first place? So intuitively, it may seem kind of weird why schizophrenia may be, misdiagnosed, or you may give someone with autism a diagnosis incorrectly. But actually, these disorders do share a lot of common sort of behavioral characteristics and cognitive deficits. And one of the main ones is their sort of shared similarity of social dysfunction. So, as I said, for a long time, or overlap between these disorders cause a lot of confusions, and so many young people with ASD were thought childhood version of schizophrenia. But symptoms of ASD, as we've learned, they can be seen very early. Instead of schizophrenia, typically occurs in young adulthood, and individuals who have schizophrenia often experience hallucinations, which are far less common than in ASD. But as I said, both of them, they experience difficulties with across both of these disorders. They experience difficulties in social interaction. So both groups are known to be poor at recognizing social cues. They often have defining emotion in other people. So far so that their reactions may seem inappropriate. They may not pick up on subtle cues and interactions. And adults with ASD or schizophrenia may alienate other people and have trouble making friends or getting along with others. And there's also some evidence for shared kind of genetic factors of these disorders of autism and schizophrenia. The next question is, we discussed how eye tracking is a promising endophenotype in schizophrenia. Is this marker considered to be sensitive or specific? So this marker is considered to be sensitive. A good marker is that sensitivity is sort of the ability, I guess in this context, the ability of this particular endophenotype to correctly identify those with the disease or the disorder. So it's kind of like the true positive rate. whereas specificity is the ability of the endophenotype to correctly identify those without the disease, so the true negative rate. So with eye tracking, that it has pretty good sensitivity, and there's research going into trying to improve its specificity, but we're still not there yet. So eye tracking is really good at being able to identify those with the disorder or with schizophrenia. And then the second part of this question, it says, can you please explain the course of schizophrenia in developing countries versus industrialized countries and why? So, kind of a controversial sort of line of research. So, out kind of in the 70s by the World Health Organization, was sort of this disparity in schizophrenia in those living in developing countries and those who were living in developed countries. And so they announced in this 5-year study that they did that patients in developing countries had fared better than those in the US and other developed countries. The second study that produced the same results. In developing countries, the WHO researchers concluded that schizophrenia patients enjoyed an exceptionally good outcomes, whereas those living in developed countries, or those living in a developed country, was a strong predictor that the person would never fully recover. So after this study, the WHO researchers obviously speculated ways that you'd be seeing better outcomes in schizophrenia in the developing countries. One of their ideas was that perhaps countries were more medication compliant. However, they found that the 3 developing countries, India, Colombia, and Nigeria, only 16% of the elderly maintained on antipsychotics, compared to the 61% of the patients in the developed countries. So outcomes seem to be better in countries where patients weren't actually regularly compliant with their medications. So this didn't seem to be this hypothesis didn't look like it panned out. So another thing that they speculated was, okay, maybe this has to do with cultural differences. And so they suggested that perhaps patients in the developing or more poorer countries are not as isolated as developed countries. Maybe they're better able to find work. Really, the reasons haven't. And so I can't really give you a conclusive answer, but I think what's important to remember here, this finding indicates that the relevance of sort of cultural factors in the course and sort of prognosis of schizophrenia, and better prognosis and outcomes in developing countries could result from different sets of etiological and perpetuating factors, and we're still trying to figure those things out. Okay, so those are all the questions that were posted on the discussion board. So if you guys have any more questions, just post them on the board, or you can actually just post them in the chat, and I'll answer them till 8:30. Okay, guys, that's the end of the review session. Thanks for all your questions, and good luck tomorrow.